Good morning, everyone. So today I will be discussing on the subgroup study 7, which is on antimicrobial resistant surveillance of gram-negative bacilli, namely Enterobacterial, Pseudomonas aeruginosa, and Acinetobacter baumannii complex, clinical isolate obtained from the intensive with special emphasis to carbapenem-resistant organism against the specific set of antimicrobials included in Vitek GN-AST 407 card. This is the primary objective of the study. So the primary objective will be to conduct the AMR surveillance of gram-negative bacilli, namely Enterobacterials, Pseudomonas aeruginosa, and Acinetobacter baumannii complex clinical isolate from the ICUs antimicrobial included in GN AST 407 critical care card. And the second primary objective will be to conduct the AMR surveillance of carbapenem-resistant organism, namely CRE, CRPA, and CRAB from the ICU against the antimicrobial included in GN 407 card. The secondary objective of the study will be to compare the percentage susceptibility of polymyxin BLI such as ceftazidime avibactam and ceftolozane tazobactam among the CRE and CRPA clinical isolates.
Just to bring
Now, why we are conducting this study? As we know that in our day-to-day clinical practice, we come across CRE, CRPA, and CRAB isolate in our day-to-day clinical practice. So these spreads rapidly among the patients who are hospitalized, and because they are plasmid mediated and they can rapidly spread among patients. But to combat those, we need specific antimicrobial therapy and this important antimicrobial susceptibility informations are not available through N405, N406 panel. VAMR has come up with 407 critical care card, which has important BLBLI antibiotics, which helps in the like ceftazidime avibactam, ceftolozane tazobactam, and avibactam. Those are being used for carbapenem-resistant gram-negative bacilli. I'll come in detail where they are used for which purpose later. As well as other important antibiotics, the MIC of which cannot be obtained from N405 or 406 card, like polymyxin B, chloramphenicol, tobramycin, and the most important one is the ESBL confirmatory test, which has been included in 407. Question is when to use this card, what is the criteria, because this is very dicey, it is very variable because it is differ from institute to institute. The selection criteria, some important rules can be employed for using this 407. The most important one is that you can based on the resistant pattern of the isolate. For example, all carbapenem resistant gram-negative isolate or randomly more resistant organism like extensively drug resistant XDR or pan-drug resistant organism can be tested, or else it can be based on the patient care location. That is, you are testing only all ICU GNB isolate for N407, or it could be specialty specific, like isolate from the any particular department, like medicine or pediatrics can be chosen, or it could be specimen specific. All blood GNB can be tested, or it can be the ideal one will be the combination of the previous filter such as all ICU carbapenem resistant GNB isolate can be chosen for N407 card. Okay, but whatever you choose and fix, that you need to follow all throughout the study to get a robust antibiogram. So the contribution, what is the contribution of N407 for antibiogram? Routine antibiogram cannot be prepared for the antimicrobial agents included in 407 because they are not routinely tested isolate. But however, enhanced or stratified antibiogram can be prepared based on the various stratified filters such as patient care location, specialty, then the specimen type or specific resistant phenotype like CRO can be prepared if the 407 card is used based on a specific set of prefixed rule. Like as I told you, all ICU GNB carbapenem resistant. So that can be fixed as a criteria for using N407. So to simplify that, the VAMR group recommends to include two methods of isolate selection. One is the all GNB, all ICU GNB isolate, or you can choose all ICU carbapenem resistant gram-negative isolate. For example, CRE, CRPA, and CRAB. Okay, so you can choose either of this method. Okay, so we will accept both. You can choose any of this which are acceptable for the N407 study. So this isolate will be obtained from the clinical sample and will be further processed for testing AST using N407 card. So these are our inclusion criteria, that the clinical isolates obtained from the culture of any clinical specimen from the patient admitted in all intensive care unit of the healthcare facility with either of this inclusion criteria should be fitted into it. Inclusion criteria number 1 is all non-duplicate GNB, namely Enterobacterial, Pseudomonas aeruginosa, and Acinetobacter baumannii complex. And inclusion criteria 2 is all non-duplicate carbapenem resistant gram-negative bacilli, namely CRE or CRPA or CRAB. Okay, so you can choose either of this criteria for using your N407 card. And exclusion criteria means isolate obtained from the surveillance sample, like from the patient or from the environment or from the healthcare worker, and outbreak isolates should be excluded from the study. Coming to the methodology. So initially you will be using 405 or 406 card. From there you will get the information of the carbapenem susceptible result. So if you're using 405, you'll be getting the information about imipenem, meropenem, and artapenem. If you're using 406, you'll be getting the MIC of imipenem. Optional is the secondary testing using curvilinear diffusion method. So what we have said, the definition of carbapenem resistant for this study. If your isolate showing resistance to any of the carbapenem tested, that should be regarded as CRE and will be processed further for using N407 card. So the next step will be a must-do step for all the center. There is antimicrobial susceptibility testing using your critical card. So AST of all gram-negative bacilli or all carbapenem resistant organism included in the study, namely Enterobacterials, Pseudomonas aeruginosa, and Acinetobacter baumannii complex, will be processed using the N407 critical care card. So these are the name of the antibiotics listed under N407 with their drug concentration tested and the calling range. As you can see, the ampicillin sulbactam, these are the different drug concentration tested, and the calling range is 2 and 32. It is used mainly for carbapenem resistant Acinetobacter baumannii. Then the second one is cefepime. The calling range is 0.12 to 1 and 32. More than 32 is resistant, less than equal to 0.12 sensitive. Is mainly used for MC beta lactamases producing Enterobacterials and Pseudomonas aeruginosa. Again, it is a vital marker for MC production. If it is showing resistance to cefoxitin, that means the isolate probably is a MC producer. Then the important one is the ceftazidime avibactam. The calling range is 0.1 to below, less than equal to 0.12 is sensitive. Below 8 is sensitive, and above 16 is considered to be resistant. Okay, that is mainly used for carbapenem resistant enterobacterial, especially if center is able to detect carbapenem resistant gene. So it is active mainly against KPC and OXA48 producer, and a combination therapy is required with aztreonam in case of MBL producing organism. Then the next one is ceftriaxone. Ceftriaxone is again the calling range is 1 and 64. It is not available in India. Ceftolozane tazobactam, again another important antibiotic which is mainly indicated in case of severe carbapenem resistant aeruginosa primarily, and for carbapenem resistant other gram negative, especially the KPC producer. Then the ESBL confirmatory test in 407 card based on testing your fourth generation cephalosporin, cefepime, and third generation cephalosporin like cefotaxime or ceftazidime with or without clavulanic acid. Okay, to test for so it will flag as positive or negative. So this information is again vital for before choosing antimicrobial therapy for ESBL producing enterobacteriaceae. So the other drugs included in the panel are levofloxacin, meropenem, uh, colistin, polymyxin B, MIC will be getting in addition to your 405. Then the other one is tetracycline MIC, doxycycline MIC, tobramycin, again an important drug which can be considered in case of difficult to treat resistant case aeruginosa, DTR, Pseudomonas aeruginosa, if other antimicrobials are found to be resistant. Then MIC, you'll be getting MIC for nitylmycin and chloramphenicol. Coming to the QC, weekly preferable or once monthly or twice monthly is also acceptable. And the reference strain are used for N407 are ATCC E. coli 25922 and Pseudomonas aeruginosa 278. So those are routinely tested ATCC, which can be used for quality checkup in 407 card. Now coming to the data entry, the data entry related to the study need to be entered directly through the IVAR platform, same like the way you are doing in phase 1, as well as is continuing in phase 2. And we'll be having a N407 Vitec panel. We'll fix it as like N405 and N406. Just the data will be created from the Vitec, and the additional secondary test if can be entered into the. So these are my references. So you can, if you have any doubt, you can ask regarding isolate selection criteria. Or so we are basically open with both the inclusion criteria. So either you can all ICU GNB or all ICU carbapenem resistant GNB.
Partho, yes.
Yes.
Yeah, Partho, nicely made presentation. So, one or two observations from my side. We are including crab. What is the utility of including crab in this? Because if you see the sensitivity pattern comes out from N407, it hardly has any active antimicrobials apart from this ampicillin sulbactam, which is not given in my system. I don't know about your system. It's not reported in my system. They have locked it. So other than that, what is the utility of having crab in 407? Number one. And
that is the only utility of crab. Using the 407 for CRAB. Because in my place, we see the ampicillin sulbactam MIC, and ampicillin sulbactam is available.
Yeah, that is okay,
available.
but maybe due to some of the glitches, I'm not getting the results. The only point is having ampicillin sulbactam. No.
Yes, yes.
So that is okay with me. And do you want to
anyway, because ICMR also recommends ampicillin sulbactam.
Yeah, ampicillin
before
sulbactam.
hydrosulbactam was
Yes.
before hydrosulbactam was considered for drug of choice.
Agreed.
Now ampicillin sulbactam.
That is absolutely well taken. And what do you want us to do that we go simultaneously with N405 and 407 and 407, or we'll go by stepwise testing? Like first we test it for carbapenem resistance, then we'll go for 407. So
see, we can straightforward because anyway we are using combination of most of the center are using combination of this two. Initially they are putting up N405 or 406, then followed by if the isolate is resistant to carbapenems or most of the antimicrobial tested in 405, then they'll put to check for the other important BLI and polymyxins and chloramphenicol. Okay, those are additional thing. But if you are selecting all ICU GNB, automatically you are testing for your carbapenem resistant isolate within it. So better if you test all ICU GNB with 407, then it is fine. Okay, but you definitely you have to use.
So,
No,
what I'm right now, what I'm doing is I'm doing for all my ICU blood GNB isolates. What
Okay.
right now, what I am doing.
Okay.
So there are many samples which may not need, like, say, for example, if you talk to the clinician, they still keep on sending you drain fluids and all these things that will give no clinical relevance.
Hmm.
So for that, I wish we could exclusion criteria that will not make some clinical relevance, like respiratory samples, your blood isolates, your proper samples are okay with me.
Okay.
But some of the clinical isolates should be excluded from the study. What I am getting from my institute.
Okay. For example, like those you are thinking as a colonizer.
Yeah.
Okay. But here, if it is clinically relevant and we are processing for Vitek, then we can include those. You may not include those from your center, but other center may include if they found it clinically relevant.
Yeah,
what
that
is
is what. Say for
what
example, they are doing lots of because I'm working in a cancer hospital and they are doing lots of abdominal surgery and then putting pelvic drains. After 48 hours, these pelvic drains are bound to be colonized with something.
Hmm.
So they will be growing here anyway.
Yes. Okay,
what I
Ketan, you
understood?
want to add anything?
Yeah, what I understood with
Sir, are you reporting those?
No.
So then it is not a part of the study.
Yeah, and problem is that sometimes currently I'm not reporting it. Sometimes the doctors keep on telling us, please do report all these things because we thought this is a clinically significant isolate. But what during my IC rounds, what I see that these are mostly colonizers,
Hmm.
nothing to do
what
with the
let me streamline the discussion. So
yeah
what was the first part of discussion was is whether to make Acinetobacter baumannii complex as a compulsory thing,
yeah
or the query was whether can it be made at an optional thing.
yeah
So so this is the first discussion what we are having. So enter Pseudomonas aeruginosa. See, when we talk about GNB, we primarily keep ourselves restricted to these three groups: Enterobacterus, Pseudomonas aeruginosa, and Acinetobacter. We are excluding all other organism groups as far as this studies, subgroup study is concerned. Now, the question raised was, do we need to make Acinetobacter baumannii complex as a compulsory, or it can be made as an optional? The institute given commitment that they'll be including all Acinetobacter baumannii complex. Enterobacterus and Pseudomonas aeruginosa, there cannot be any filter. So the first point is considering Acinetobacter as an optional. The institute decide whether they'll include all of them, they will exclude all of them. Testing for some and testing for some and not testing for some cannot be an option. So this thing will decide, and I'll will in the subsequent meeting we'll let you know. Point taken that Enterobacterus Pseudomonas aeruginosa as a gram negatives to be tested in N407. Acinetobacter baumannii complex, can we give it as an optional thing for individual institutes? Those will commit to add it. They'll have to add all the Acinetobacter baumannii complex. Those will exclude and choose not to test it. They'll not be submitting any Acinetobacter. So this was point number 2. Second point which was raised is whether to go with simultaneous listing of 405 6 and 407, or it can be a stepped manner. First we test for 405 406 and subsequently we'll test for 407. So this that's why we have kept, for this reason only, we have kept two staged inclusion criteria. All those centers who choose to include all intensive care unit patients sample and test it simultaneously, their inclusion criteria is going to be all ICU GNBs, because you're not going to filter out you do it simultaneously 405 406 as well as test 407 data. So that will be your simultaneous listing. Your inclusion will be all ICU GNBs. For all those centers who have a protocol of doing stepped testing, you first go for 406 407. Then if that comes out to be carbapenem resistant, you have to go for 407 testing. Again, I like to pinpoint a very important factor, that the criteria is only resistance. Suppose you do a testing with 400, this commitment is needed from your institute. I'll tell you why. Suppose you test your isolate with 406, an ICU isolate for 406, 407, you get carbapenem resistance, but other non-beta-lactam like quinolones and cotrimoxazole, etc., hundreds of antibiotics are susceptible. Then you cannot omit 407, saying that I have still three class or 4 class of antibiotics susceptible. So why to test for any additional panel? That won't be the case. If your 405, 406 is going to be carbapenem resistance, you have to include 407 in the stepped manner, irrespective of other classes susceptible or resistant. This commitment is needed. You can have only filter at simultaneous testing. You'll include all ICUs. Step testing, you screen for carbapenem resistance in 405, 406. Then to be carbapenem resistant, you include in 407. Based on that, you include the inclusion criteria. This is point number 2, what we are discussing. Okay, this we have the clarity. The institute has to commit to either of those. You cannot put on a filter. Now, third question asked is, do we need to put a sample specific filter? Like currently we are going with only 2 filters. We have discussed so many filters that in a 407 testing or a stratified testing, many filters can be raised. Currently, we are agreeing to one filter as it should be an ICU isolate, all ICU isolate. It should be another filter is resistance pattern, that is carbapenem resistance. Now, the question asked in the discussion is whether sample should be a additional filter. Those institutes who want to test all ICU, GNB, or all ICU CR isolates, CROs, but for a particular sample, like for example, that sample discussed now or questions now is blood. Other than blood, or maybe blood and respi, not others. Is it going to be allowed in the study? This is point number 3. This is another thing which will take a call and will subsequently tell you in the next meeting. But again, I would like to tell one important point, that if this filter, the third point filter or a sample filter is introduced as an inclusion criteria, then if you select to begin with that you include blood, respi and pus samples in your, or only blood sample or only blood and respi sample, any permutation combination of samples, if you commit to begin with, you have to test all GNB isolates from an ICU from those samples. In that isolate, in that sample, you that this I'll test, this I don't test. 1 point. Considering that are clinically significant. Always antibiogram submission is based on what you seem as a pathogen, what you seem as a commensal, what you seem not to be reported to a patient need not be part of antibiogram. This is a basic rule. This we are not discussing. Now, if you choose to exclude urine or any particular sample like stool, exudate or whatever, then none of the samples would be submitted in the study. So if you commit for this, if we introduce, I'm not telling you will introduce, we'll have a discussion and we'll let you know in the subsequent meeting. This point is well taken to make organism as an optional with Acinetobacter. This point is well taken, that including sample criteria, sample filter as a point. But if we introduce that in the study, then you have to stick to those samples. All GNBs or all CRGNB sample you have to include. None of the other will be included. Okay, so these 3 are the discussions so far we had. I just filled it in place for others to, because this may be an issue which other centers may be in mind. So organism will let you know about it. Whether specimen filter is introduced in the inclusion criteria, will let you know about that. Sequential or step testing, this you understood that you have to choose any of the criteria based on how you have a practice in your 4-not testings, simultaneous or step 1. Okay. Have I addressed all the issues so far?
Thank you so much. Address all of it. Thank you.
Yeah. Any other query we have other than these discussions?
Are we going to submit 407 cards separately or like we are submitting in the IBAR right now? 406, 407 card both. So
Yeah.
do I have to submit it separately now?
No,
407
I'll tell you, ma'am. I'll tell you what will go on when you open the screen. Whenever the organism name is there, on the little right of hand there is a panel. When you go into
Right.
the drop down, so many Vitek panels open. Correct. One of
Right.
those 405, 406, and other redundant panels, as well as 407 panel. So those centers which are being to be part of this 407 study, now on when the study starts, when subgroup study starts, 407 panel will be active only for those which are going to be part of 407 study. For any rule, any filter. If you are not part of N407 study, then the N407 drop down in that panel will be made redundant for you. So all the other centers which are not being part of N407 now cannot submit their 407 data, because what is happening in phase now is that 407 is too random, and sometimes some institutes submit the 407 data and some not. This is going to deviate our antibiogram. This is going to dilute the antibiogram in a wrong way. So now onwards, those will participate. For them only the 407 panel will be active. They can, same way how we do the entry, your organism name will come, you have to select N407 and we'll keep an additional. Now, like for example, one organism you will be submitting, you will maybe submitting 405 data as well as 407 data. So we'll give you an option to submit the same organism twice with 407 and 405 also. Or we'll create a common platform, 405 plus 407, 406 plus 407, as well as 407 as a separate entity. So these are the panel combinations which will be given, provided to you, but it will be active only for those centers who are sub-study. It will all be inactivated for those centers who are not part of the study. Am I clear now?
Yeah, thank you.
So we are using 407 for ICU and non-ICU blood isolates. So then how to go?
Ma'am, this is little tricky. So I'll suggest you to change your protocol. Is it possible to change your protocol for, or you can enroll your N407 for ICU isolates, but is it possible for you to move it to all ICU GNBs? Is it possible?
Then actually I'm not doing it in a step manner. So considering that the sepsis patients are critical and they may land up in ICU at any time.
Okay, so I agreed, ma'am. So let us take a call on that I already discussed. If suppose we include the specimen filter, I am hopeful we'll include it. So in that case, you can send only your all ICU blood GNB data. Okay, that will be only submitted from your center to the subgroup study. We won't be including all non-ICU blood isolate data. That we are not taking for sure. So in this case, all you will be testing it irrespective of its resistance pattern, correct?
Yes.
Okay, so because you're doing a simultaneous listing, so in that case, your inclusion for your institute inclusion will become all ICU blood GNBs.
Because step testing becomes a little bit expensive, and many times clinicians are not agreed to do double entry for, or even lab is not able to test the 2 cards for single sample.
No,
And
I
407
agree.
is
I
little
agree
bit
with it.
expensive than 5 and 6.
Yes. Okay, so I agree with your point. So in all the institutes who have this kind of scenario, what ma'am is discussing, then in those cases, if we introduce the specimen inclusion criteria in that, then for those centers, all ICU blood GNB is going to be the filter which under which they'll be submitting, but they have to test all blood GNBs, which Enterobacter, Pseudomonas aeruginosa, Acinetobacter baumannii. All blood
Yes.
ICU isolates you have to include in the sub-study.
Yes.
Agreed.
Okay, thank you.
In
But
our
Ketan,
case,
for
we
those
are testing.
case, Ketan, for this case, they have to do simultaneous testing, right?
Yes.
Because if they include only all ICU blood GNB, then they have to perform simultaneous 405 or plus 407.
Yeah. With this criteria, simultaneous or stepped doesn't matter much, because but they can't skip it. They have to do 407 testing in all. Doing simultaneous makes more sense, because when we are not testing based on any specific resistance pattern of 405 furnaces. Why to waste a time in getting 405 result and then putting on 407? If you are anyway going to give that all the GNBs in your blood for ICU are going to be tested, doing it simultaneously, putting it simultaneously makes more reasonable sense. So that this institute is doing also.
So in case of simultaneous testing, for all ICU isolates, we'll be submitting carbapenem susceptible organisms also?
Ma'am, in that case, yes, ma'am.
Yeah.
Carbapenem susceptible also is. In true sense, when I say antibiogram is best prepared in that way, we are diluting it with carbapenem resistance just for the sake of preventing a waste of money. In actuality, any antibiotics antibiogram must be prepared for all isolate, irrespective of its resistance or resistance patterns or anything. Then only you'll get a true picture of S%. But because some of the drugs are used in carbapenem resistant organisms, that's why, and putting it on all isolate is a costly affair. That's why a midway ground is made for including is for CROs, carbapenem resistant organisms. It's not a correct way. I'm very frank. Antibiogram S% generation wise, it's not a correct way, but it's a middle ground to somehow put a balance between testing as well as generating antibiogram. So that's why it's not always done. That's why we have kept those institutes who want to include all GNBs, they are warm welcome, because that is how a true antibiogram is generated. Those who have a restriction cannot do it for all, can also include with the freedom of including only CROs.
Another question, like
Yeah.
we are putting simultaneous for all ICUs.
Yes.
And in what cases we are putting when they turn out to be carbapenem resistant? So for this study, we have to submit only ICU cases, not those
Yes.
cases which are transferred from ICU to ward and they are carbapenem resistant?
Ma'am, usually this is a little bit trickier for you, because rule wise, if this all complications we usually avoid, because if someone gets transferred from a location, any organism growing for the next 24 hours or so from the day of transfer and next day, that belongs to the previous institute. This is the rule how it goes. But because it introduces too much of complexity, we usually avoid it. Patient is in ICU, you include the sample. Suppose you are able to track those patients in ICU to ward, and you are able to find out if that isolate is getting from on the day of transfer and the next day, you can include those. But otherwise, we don't keep it as a rule. Complicates the thing. Many often we don't have the information when the patient is in ICU, when the patient gets transferred to ward and all. Same case for like a patient is in emergency, blood sample is taken, and blood culture is taken, sent for culture, and simultaneously the patient is moved to ICU. Now, if we have the information that patient has been moved to ICU, you include that isolate. If your HIS reads emergency and you are not able to track those patients, whether currently in which location, don't include those patients. So location-based tracking, if it's available, if you take the extra mile to know the current location of the patient, an emergency sent sample, a sample which reads emergency in the HIS, and the patient is currently in ICU, you can include that also as an ICU isolate. Secondly, if the patient is discharged from ICU and that day of discharge, on the next day, if someone gets a culture, be included. But considering only the point that you are able to track it, most of the time we are not able to track it. Most of the time, our information on patient's location is what is mentioned on HIS. And HIS, the location is mentioned is from which location the test has been raised. So those which have been raised from ward, those which have been raised from emergency, need not be included if you're not able to track the patient's whereabout in ICU or not. Better, that's an easy way out. Hope I solved the issue, ma'am.
Yeah, thank you.
Good afternoon, sir.
Yeah, ma'am.
Sir, so currently what I've understood, we will be including all the ICU sample and all the type of sample, right? We have not categorized the sample type.
Currently, we are not.
So if we wish to sample type, we want to do only supposedly only the blood sample from all the ICUs. Can we do that?
Yeah, that is what I've told, ma'am, in some time back, that currently in today's discussion we have not included specimen filter, but because that issue has been raised, and I believe it will be a point of emphasis for many of the institutes doing 407 testing. Will in our internal committee will discuss that, and I'm very hopeful that will include a specimen. So there will for those and that will be only discussing you with in the subsequent meeting. If that discussion will happen, I'm hopeful for that. Then you will be able to submit all ICU, all blood GNBs. Means you will be having a freedom to choose your specimens also, like blood, like respi, like exudate. But you have to commit to your specimens from ICU, which you are going to do blood 407 to begin of the study. You have to decide SP, exudate, or whatever, or all specimens, what you are going to put on. And then you will be able to submit those data.
So should we wait till then, sir, or should we
We'll-
start
We'll let you
the
know.
process?
We'll let you know in one day, ma'am.
Okay, okay, sir.
Yeah,
Okay.
it will not
Thank
take. What is an internal discussion we'll have? So it will take just 1 hour or so, less than that.
Okay, sir.
Yeah,
Okay,
maybe by
good.
the evening only we'll let you know.
Okay, thank you so much, sir.
We have well taken the points discussed today. Any other issue? Because this among all the topics, this is somewhere where we expect the participating institutes to have hundreds of doubts. What has been raised, they're all genuine issues. They were in our mind also. So that's why it's many of you who wouldn't have asked their queries would have got the answer from the discussion what we had. Any other permutation combination of 407 uses doubts if you have, we are free to address that, because this is the only thing which we want to streamline. 407 uses differences are huge in among institutes. So if you don't have any then I presume discussions, whatever has happened so far has solved the points, queries of all other institutes. Okay, in that the case, then.
So if somebody was like 407 card multiple times, they would agree that more or less for CRO specifically, like and pseudomonas, we'll usually get susceptibility more often only polymyxin and colistin, and that's why the reason is, and the thing which we look for in 407 is ceftazidime avibactam, and many times it would ultimately we go for the synergy testing and this thing. So my query is, if it is so that the whole panel of 407 is eventually going to be coming out more or less resistant, yeah, I'm agreeing that once in a while we do get sensitivity to ceftazidime avibactam or something. But otherwise, what exactly we are looking for? Is there anything which we have as an objective which will be satisfied out of this? If you are looking for the therapeutic options, it is very clear that for pseudo it will be Mino, and for the Klebsiella it will be either sometimes ceftazidime avibactam, or it will be poly-B and colistin MICs itself. That's it.
Other non-beta lactam, that beta lactam, sir, we'll be looking into non-beta lactam susceptibility percentages like netilmycin, tobramycin among aminoglycosides. We'll be looking into chloramphenicol, even if therapeutically it is not very much nowadays, not very commonly used. But as a last resort, so these drugs, which are non-beta lactam drugs, beta lactams may newer BLB, like you are very apt that is the only reason we'll look into N407 card. But non-beta lactams may, I can remember aminoglycosides में tobra and netylmycin are entries which susceptibility wise we don't know. Tobra compared to genta and amica, it's a good glycoside. Netyl is again one option. Chloramphenicol we are in this having in this panel. Paul B.
Yes.
Well, only time will tell that how reliable this card is for Paul B resistance. But for now, if we take it, then that is another entry. Colistin Paul B mismatch kind of situations because it tests for both. Is where we're looking forward. In general overview, I am on the same pace that this card is going to give soon because the main indication was ceftazidime. Now we have plenty of testing methodologies to look for susceptibility as well as synergy. So, but if we test it, let's test it in a very strict, stringent way. So make the testing useful and make some sense. So this is what's the plan of this subgroup study.
Yeah, and the second thing what you told is tobramycin and netilmycin. So again, our experience mostly it will come out to be resistance 1, and then non-beta lactam antibiotic such as these, how often it will be therapeutic based, because we are talking about an intensive care card. They'll not go for tobramycin or netilmycin. The patient is not in that state that even if it is susceptible here, that option will be gradually taken up, or it will actually be it will have a real therapeutic value also. So can we like just think about it? Like can we do something to actually show? I don't know. I'm stuck here because first of all, I've not seen Tobra and netilmycin susceptibility too much, and the other ceftolozane and other those drugs are not actually available anyway for the clinicians. So maybe because we are doing this study, maybe can we have some sort of objective? Can we add something so that it be full? I don't know. Maybe we'll have to just think. I'll also think and get back.
Yeah,
But
we'll think on
otherwise,
that,
I
sir,
think
and
we should add
will be
something.
a welcome for this is a very genuine question, giving more purpose to the study. So we had some purpose in our mind, but giving it more a clinical oriented, a therapeutic oriented purpose will be a nice thought process. So we'll encourage all the other centers to thought on the things. Share your will. Anyway, we'll be creating a WhatsApp. Your thoughts. Let's bring more objectivity. Let's bring more purpose to this study. Our main purpose is not see. I am a very common advocate of using uh, trying your non-beta lactam options currently because our BLBs I count that as a beta lactams only. So beta lactams are the safest drug to administer. You don't need to worry about interactions. You don't need to other side effects harming your systems. So mostly we are stuck around that. So that's why when someone talks about carbapenem resistance, we jump for newer BLB. Like, okay, this is the thought process how it goes. Even the guidelines go in the same way, but it's not like that. So PLBLIs have a different resistance mechanism. Coexisting resistance, I agree, may or may not exist, but your beta lactam is a carbapenem resistant organism, or neonabilbili is also not effective considering what type of carbapenem it is. Why not look for non-beta lactam options? Okay, like aminoglycosides cannot be used as a monotherapy. They'll always adjuvant you as a depending on what organism you're treating, because pseudomonas and all other effects are subpar. So definitely non-beta lactams will give you an adjunctive therapy or a supplemental or a combination therapy options if your beta lactam or in your BLBI is failing or not giving you a good results. This is one thought process I have in my mind while looking into these antibiotics, which are not usually part of our 405, 406, but I'm too open for having a discussion or having a thought process. So all of our centers can thought of on the same line what Saja sir has told, and let's come up with some change, some objective. If we thought of to make it this subgroup study a more therapeutically useful one, we are open. I'll also thought on the process correctly, sir.
Yeah, thanks, Ketan. I also recently a case of urosepsis by carbapenem resistant Pseudomonas aeruginosa, DTR. Okay, so it was Indian producer, and it was there was synergy negative, septa-heavy synergy negative. But we had put 407, the Tobra MIC was in the susceptible range, and we did the fosfomycin test also. The fosfomycin was found to be sensitive, so we used adjunctive therapy with fosfomycin and tobramycin. And after 48 hours, patient responded well. Patient responded well. The source of infection, the catheter which was put, was removed, and now the patient is doing well. So that I just thought of sharing just to give you the idea. Okay, we can think of non-beta-lactam
If you ask
therapy.
current generation on this question and don't disclose the other susceptibility what you did, the straight answer received will be we'll go for ceftazidime combination because you got an NDM producer. So this is how our current thought process is. You
Correct.
think you only in the line of newer BLBLIs or a beta-lactam therapy. Guidelines are all moving in the same direction. We somehow forgetting the other non-beta-lactams. Maybe it's a coexisting resistance or they're already existing high resistance, but in that they have their importance, if not as a monotherapy, definitely as a combination therapy.
Yes.
Okay, so we'll have our discussion. So we'll be having lots of discussions in the group, out of group, in subsequent meetings. So I think we can close this meeting for now without taking much time for others. So any other institute who has later on joined out, whose attendance we have not marked, just tell your VMR number. Sarvanam, you just mark out in your Excel. Any institute which has joined later on, whose institute's attendance we have not marked? Oh, not. I think not. So, okay, Dr. Barth, then we can.
Yeah.
Okay, thank you all for joining. So we'll create a WhatsApp group with these, with ours, all the institutes which are interested, and let's have a healthy discussion subsequently also on this card's utility. Thank you all.